A very warm good evening to all my dear students, friends, colleagues, and seniors. Today we are going to study a very important topic called as the thyroid gland. Okay, so moving on forward, we would be firstly studying about what all are the learning objectives in this topic. Learning objective, that means what you will be able to understand after studying this topic. First, the development and anatomy of the thyroid gland, the physiology and investigation of thyroid functions, the treatment of thyrotoxicosis and thyroid failure, the indications for and technique of thyroid surgery, the management of thyroid cancer. Then mention some of the important questions which can be asked in the examination are: mention the causes of thyrotoxicosis, discuss the clinical features and management of primary thyrotoxicosis, classify thyroid neoplasms, discuss the management of solitary thyroid nodule, and some others. Another important is discuss the etiology, clinical features, diagnosis and treatment of Graves' disease. Short notes can be asked on complications of thyroid surgery, development of thyroid and anomalies, ectopic thyroid, eye sense in Graves' disease, Joe Wisdow, thyrotoxicosis, Main syndrome, thyroglossal cyst or fistula, and thyroid storm. Clinical anatomy. What does clinical anatomy basically mean? Clinical anatomy means that how, when, and where the particular gland is located. Okay, vascular supply, as we can see, it is from the external carotid artery, superior thyroid artery and vein, internal jugular vein, middle thyroid vein, inferior thyroid artery, thyrocervical trunk, subclavian artery, inferior thyroid vein, and left brachiocephalic or innominate vein. Lymphatic drainage, most important when considering surgical treatment of thyroid carcinoma. Paratracheal nodes, tracheo-esophageal groove lymph nodes, mediastinal nodes in the anterior and superior position, jugular lymph nodes in the upper, middle, and lower distribution, and retropharyngeal and esophageal lymph nodes. Laterally, cervical lymph nodes within the posterior triangle. Papillary carcinoma of the thyroid is commonly associated with adjacent nodal metastasis. Medullary carcinoma has a strong predilection for metastatic lymphatic involvement, usually within the central compartment, the space within the internal jugular veins. Relations. The gland is enclosed in the pretracheal fascia, covered by the strap muscles and overlapped by the sternocleidomastoid. Anterior jugular veins force over the isthmus. On the deep aspect of the thyroid lie the larynx and the trachea, with the pharynx and esophagus behind, and the carotid sheath on either side. Two nerves lie in close relationship to the gland. In the group between the trachea and esophagus lies the recurrent laryngeal nerve, and deep to the upper pole lies the external branch of the superior laryngeal nerve passing to the cricothyroid muscle. So this is the diagram of the relations. Please have a careful look at it. Okay, the venous drainage. Superior thyroid vein follows superior thyroid artery drains into the internal jugular vein. Middle thyroid vein drains into the internal jugular vein, inferior thyroid vein, both sides join at midline, drains into the left brachiocephalic vein. Physiology. Iodide trapping, oxidation to iodine by thyroid peroxidase, iodination of tyrosine residues to mono and diiodotyrosine and coupling. Hormone synthesis. This is a diagram depicting the hormone synthesis. Okay, so first there is TRS, negative feedback inhibition, then TSH, then thirdly stimulatory effect, thyroid hormone target organs. Okay, physiology. Uh, TRH TRH is secreted by the hypothalamus, stimulates TSH secreted by the anterior pituitary, stimulates the thyroid gland to synthesize T3 and T4. T3 and T4 have negative feedback inhibition on TSH and TRH. The thyroid hormones secreted by the gland are in bound form and free form. Free form is biologically active The hormones once liberated are bound to serum proteins. T3 has a rapid onset of action and a much shorter half-life than T4. Okay, moving on forward, now some of the congenital diseases. Development. Thyroid develops from a bud which pushes out from the floor of the pharynx and then descends to its definitive position in the neck. Thyroglossal cyst. Okay, lingual thyroid occurs as a failure of normal descent of the thyroid, presents as a lump in the foramen cecum or in the front of the neck near the body of the head bone. In all cases of unexplained nodules in the line of the thyroid descent, radioiodine scan should be performed to ensure that there is normal thyroid tissue in the correct place before the lump is removed. Ectopic thyroid tissue can be found in the central compartment of the neck under the lower poles of normal thyroid or in the anterior mediastinum. Pendred syndrome, a rare autosomal recessive condition characterized by incomplete oxidation of trapped iodide prior to organification, associated with sensory neural deafness, mild primary hypothyroidism with a non-toxic diffuse goiter. It may be confirmed by a positive perchlorate discharge test. Now, tests of thyroid function, evaluation of pituitary thyroid feedback loop, serum TSH assay, TRH stimulation test. Serum T3 and T4 levels, only a small fraction of total 0.03% of T4 and 0.3% of T3 is free. Assays of total hormones are now obsolete. Estimation of free T3 and T4, T3 resin uptake test. Thyroid antibodies, TP antibodies, anti-thyroglobulin antibodies, antimicrosomal antibodies. Thyroid imaging, first is chest X-ray. Okay. Second is ultrasonography helps in determining the nature of the swelling. Ultrasonography guided FNSE helps in detecting metastatic lymph nodes and then the follow-up. CT scan to know the extent of malignancy and retrosternal extension. Thyroid scintigraphy provide information about thyroid activity, the size and extent of the gland, help in showing retrosternal extension. Material uses technetium 99, iodine 123 and 131. There are cold nodule, hot nodule, warm nodule. Okay, the principal benefits of isotope scanning are in confirming the presence of hot toxic nodule in the thyroid gland in a thyrotoxic patient and in identifying metastasis or residual local disease after total thyroidectomy for carcinoma. A hot nodule is one. Again, in thyroid scintigraphy, a hot nodule is one that takes up isotope, while the surrounding thyroid tissue does not. Here, the surrounding thyroid tissue is inactive because the nodule is producing such high levels of thyroid hormones that TSH secretion is suppressed. A warm nodule takes up isotope, as does the normal thyroid tissue around it. A cool nodule does not take up isotope. FNAC, IOC for discrete thyroid swellings, thyroid non-diagnostic, thyroid 2 non-neoplastic, thyroid 3 follicular, thyroid 4 suspicious of malignancy, thyroid 5 malignant. This means serum calcitonin, serum thyroglobulin concentrations greater than 50 microgram per liter indicate probable residual or recurrent tumor. Concentrations greater than 100 microgram per liter strongly suggest the presence of pulmonary or skeletal metastasis. Flow cytometry for identifying diploid tumors which have a good prognosis and aneuploid tumors which have a poor prognosis. Clinical features. There are two broad categories of symptoms, those occurring as a result of the enlargement of the gland itself and those related to its disordered endocrine activity. The history will establish whether one or both classes of symptoms are present, and examination then aims to elicit the relevant physical signs. Next symptoms, lump in the neck, discomfort on swallowing, then dyspnea and hoarseness. Disorders of thyroid hormones, hypothyroidism, adult in adults, that is myxedema. In hypothyroidism in adults, there is decreased secretion of the thyroid hormones. It could cause primary hypothyroidism, autoimmune disease such as Hashimoto's thyroiditis, due to lack of iodine, absence of deiodination of iodine. Okay, follicular cells become less active. Hypothyroidism, autoimmune thyroiditis, chronic lymphocytic, there's non-goitrous primary myxedema, goitrous Hashimoto's disease, iatrogenic after thyroidectomy, after radioiodine therapy, drug induced. Okay. This hormogenesis but Trojans, okay, thyroid genesis. Tetanism, inadequate thyroid hormone production during fetal and neonatal development. Two types, endemic and sporadic. A hoarse cry, macroglossine, umbilical hernia in a neonate with features of thyroid failure suggest the diagnosis. Adult hypothyroidism symptoms, tiredness, mental lethargy, cold intolerance, weight gain, constipation, menstrual disturbance, carpal tunnel syndrome. Signs, bradycardia, cold extremities, dry skin and hair, periorbital puffiness, hoarse voice, bradykinesis, slow movements, delayed relaxation, freeze of ankle joints. Myxedema. The signs and symptoms of hypothyroidism are the accentuated facial appearance is typical supraclavicular puffiness, a malar flush, and a yellow tinge to the skin. Myxedema coma characterized by altered mental state, hypothermia, and a precipitating medical condition, for example, cardiac failure or infection. Primary or atrophic myxedema is autoimmune disease similar to chronic lymphocytic Hashimoto's thyroiditis but without goiter formation. Diagnosis and treatment. Low T3 and T4 levels with a high TSH. What will happen in pituitary failure? High serum levels of TPO antibodies are characteristic of autoimmune disease. Treatment oral thyroxine 0.10 to 0.20 milligram as a single day dose. Thyrotoxicosis. Thyrotoxicosis versus hyperthyroidism. Hyperthyroidism is a condition in which the thyroid gland produces and excretes excessive amounts of the free thyroid hormones. Thyrotoxicosis is nothing but hypermetabolic clinical syndrome which occurs when there are elevated serum levels of T3 and or T4. Thyrotoxicosis can also occur without hyperthyroidism. Clinical types of thyrotoxicosis: diffuse toxic goiter, that is Graves' disease, toxic nodular goiter, toxic nodule hyperthyroidism due to rare causes. Thyrotoxicosis in this diffuse toxic goiter, Graves' disease occurs in younger women associated with eye signs. 50% of patients have a family history of autoimmune endocrine diseases. The whole of the functioning of thyroid tissue is involved. Hypertrophy and hyperplasia due to abnormal thyroid stimulating antibodies. Toxic nodular goiter. A simple nodular goiter is present for a long time before the hyperthyroidism. Middle-aged or elderly, very infrequently associated with eyes, and the symptom is that of secondary thyrotoxicosis. Okay, toxic nodule. A toxic nodule is a solitary overactive nodule which may be a part of generalized nodularity or a true toxic adenoma. It is autonomous and its hypertrophy and hyperplasia are not due to TSH. Thyrotoxicosis clinical features. Symptoms are tiredness, emotional lability, heat intolerance, weight loss, excessive appetite, palpitations. Signs are tachycardia, hot, moist palms, exophthalmos, lid lag retraction, agitation, thyroid goiter, and root. Graves of ophthalmopathy. This is just have a superficial look, two clinical phases, inflammatory stage and fibrotic stage. Pre-tibial myxedema elevated from non-patent localized thickening or the lateral aspect of the lower leg with bilateral involvement. Okay. Elder cases do not require therapy other than treatment of the thyrotoxicosis. Therapy with topical steroids applied under an occlusive plastic dressing film for 3 to 10 weeks has been helpful. In severe cases, pulse glucocorticoid therapy may be tried. Acropathy. Clubbing of fingers with osteoarthropathy, including periosteal newborn formation, may occur. This almost always occurs in association of ophthalmopathy and dermopathy. No therapy has been proven to be effective. TSH levels are usually suppressed to immeasurable levels less than 0.05 microliter per ml in thyrotoxicosis. Subclinical hyperthyroidism is defined as a suppressed TSH level in combination with serum concentrations of T3 and T4 that are within the reference range. Thyroid hormone circulates as T3 and T4 with 99% bound to the protein. Only the free unbound thyroid hormone is biologically active. thyroid autoantibodies. The most specific autoantibody for autoimmune thyroid disease is an enzyme-linked immunoassay ELISA for anti-TP antibody, that is thyroperoxidase. An increased disease associated with diffuse enlargement of both thyroid lobes with an elevated uptake. A toxic multinodular goiter demonstrates an enlarged thyroid with multiple nodules in areas of both increased and decreased isotope uptake. Management: antithyroid drug surgery, radioiodine. Antithyroid drugs carbimazole, methimazole, and propylthiouracil are most commonly used. Reduce the synthesis of thyroid hormones by inhibiting the iodination of tyrosine residues. Carbimazole also has an immunosuppressive action. Clinical improvement occurs within 10 to 14 days. Patient is clinically and biochemically euthyroid by 3 to 4 weeks. Treatment is continued for 12 to 18 months. Advantage: no surgery, no use of radioiodine. Disadvantage: treatment is prolonged. The failure rate is at least in almost 50%. Some goiters enlarge and become more vascular during treatment. Side effects are agranulocytosis or aplastic anemia. Surgery usually done when there is a large goiter, poor drug compliance, recurrence. Subtotal thyroidectomy is done. Contraindications: previous thyroid surgery. Complications are hypothyroidism, transient hypocalcemia, permanent hypoparathyroidism, recurrent laryngeal nerve palsy. Advantage: goiter is removed, cure is rapid and cure rate is high. Advantage: recurrence occurs in 5%. Every operation carries mortality and morbidity. Post-operative thyroid insufficiency. Radioiodine. Iodine 131 is given orally as a single dose and is trapped and organified in thyroid. Advantage: no surgery and prolonged drug. Disadvantage: isotope facilities must be available. High incidence of hyperthyroidism, which may reach 75 to 80% after 10 years. Indefinite follow-up, increased risk of malignancy. Choice: because toxic goiter over 45, radioiodine under 45, surgery. Toxic nodular goiter surgery, toxic nodule surgery, radioiodine. Recurrent thyrotoxicosis after surgery or 45, radioiodine. Okay, so I hope up till here it is clear. Correction of hyperthyroidism is important for the ophthalmopathy. Antithyroidoxine and thyroidectomy do not influence the course of ophthalmopathy, whereas radioiodine treatment may exacerbate pre-existing ophthalmopathy but can be prevented by glucocorticoids. In the long term, thyroid ablation may be beneficial for ophthalmopathy because of the decrease in antigens shared by the thyroid and the orbit in the autoimmune reactions. Decreased ophthalmopathy: for mild to moderate ophthalmopathy, local therapeutic measures like artificial tears and ointment, sunglasses, eye patches, nocturnal taping of the eyes, prisms, elevating the head at night can control the symptoms and signs. Okay. The operative preparation: carbimazole is given, iodides are given, and propanol. Post-operative complications: hemorrhage, respiratory obstruction, recurrent laryngeal nerve paralysis and voice change, thyroid insufficiency, parathyroid insufficiency, thyrotoxic crisis, wound infection, hypertrophic or keloid scar, stage granuloma. Classification of goiter: simple goiter, euthyroid, physiological, pivotal, toxic, diffuse, multinodular, and neoplastic. Classification of goiter: inflammatory, autoimmune, chronic, Hashimoto's, D. Kuberne's thyroiditis, Riddle's thyroiditis. These are some of the classifications. Simple goiter: stimulation of the thyroid gland by TSH is the most common cause of iodine deficiency, increased demand, excess iodine, or lithium ingestion. Okay. Inborn errors of metabolism causing defects in biosynthesis of thyroid hormones, thyroid hormone resistance. How goiter is formed with lack of iodine. This is a flowchart. Natural history. Clinical features: euthyroid neck swelling which moves on following rollout compressive symptoms, hardness and irregularity due to calcification may stimulate carcinoma. Okay. Investigations: serum TSH, USG neck, thyroid autoantibodies, plain X-ray neck and FNAC. Complications: respiratory obstruction, secondary thyrotoxicosis, follicular carcinoma. Prevention and treatment of simple goiter. Adult indication of surgery, cosmesis, ectodermal extension. Okay. Subtotal thyroidectomy, discrete thyroid swelling, clinically discrete swellings, indications of surgery, all proven malignant nodules, cytologically proven follicular adenoma, suspicious nodules, cystic nodules which recur following aspiration, nodules producing obstructive symptoms, toxic nodule cosmesis in patients with. Okay, so this is up till here now. I hope everybody has understood